Hello everyone and welcome to the self-learning module on understanding cardiac stress testing. My name is Mukesh Bhargava and I will be guiding you through the basics of cardiac stress testing. The self-learning module is designed for IM care and heart care. However, anyone interested in the subject is welcome to learn. The module is designed to be self-paced. Feel free to pause, rewind, and revisit any part of this presentation as needed. So why do we do a stress test? The most common reason for doing a stress test in our lab is for detection of significant obstructive coronary artery disease, which means are there blockages in the arteries? The blockages have to be significant and cause flow limitations for the stress test to be abnormal. The stress test will not detect all coronary artery disease. The other reasons for doing stress testing are to figure out exercise tolerance prior to coronary revascularization, abnormal or equivocal findings on coronary computed CT angiography, valvular heart disease, and certain arrhythmias. But the detection of obstructive coronary artery disease is the commonest reason in our lab. So when should we not do the stress test? Stress test does put the patient at risk of having symptoms, heart attack, and even death. The list of contraindications for the stress test are on the slide. These can be ascertained by simple history taking, record review, and a basic physical examination. Please go over this list at your own pace, and this should be available to you in the stress testing lab. Next up is the list of relative contraindications where a stress test may be done but would be considered high risk, and the risk-benefit analysis should be done by the supervising physician prior to stress testing on the day of testing. Please go over this list at your own pace and always consult the supervising physician prior to starting the test if any of these relative contraindications are present.
Lead placement is quite important. The chest leads are placed in the fourth and fifth intercostal space. Placing the leads higher or lower causes improper ECG. So paying attention to this every time is important. If for any reason you have to place the leads somewhere else, maybe a space higher or lower, please alert the interpreting physician. The arm and limb leads are also important and have a specific placement, but there's more room. The leg electrode should be positioned below the umbilicus and above the superior iliac crest. The arm electrode should be placed at the base of the shoulder just inside the border of the deltoid muscle, 1 to 2 centimeters below the clavicle. Now you're ready to start the stress test. You've figured out who to put on the treadmill, who not to put on the treadmill. When should you talk to the doctor prior to putting the person on the treadmill? As the patient stands on the treadmill, make sure that their posture is upright, their shoelaces are tied, and there are no cables or tubing that will interfere with their walking. Deciding when to stop the stress test is based on patient factors. Always tell the patient prior to starting the test that they should let you know if there's any reason for them to stop the test. At times people may just panic and they want the test to be stopped. Continuous direct observation of the patient is required. Some patients are determined to push through thinking that there is a pass or fail, or this is like climbing a mountain. It is useful to tell the patient that there is no specific endpoint, there is no pass or fail, and they should not overexert themselves to exhaustion. There are reasons when you, as the supervising person, will decide that you should stop the stress test, despite the patient might say that they can continue. The list of things is on the slide and include how the patient looks, what are their numbers, and what ECG changes are you seeing. At times, you will find that the rhythm or there is significant artifact and the ECG becomes uninterpretable, and it is quite important to make a judgment call that if you cannot see the ECG properly, that you may choose to terminate the stress test by ending the walking portion of the test. Watching the patient in recovery is quite important. The first ECG should be obtained as soon as the patient lays down, as it is the cleanest ECG available. The patient should be observed on the monitor until they are symptom-free and the heart rate has come down to below 100. This may take anywhere between 5 to 10 minutes. Next up for you to master is the ST segment. The ST segment is looked at through two parameters. One is the slope, whether it is upsloping, as in the top pictorial, horizontal, as in the middle pictorial, and downsloping, as in the bottom one. The second parameter is if there is ST segment depression, how much is the ST segment depression in terms of millimeters. Each small box on the ECG graph paper represents 1 millimeter ST change. Once again, a pictorial description of different types of ST segment depression. The first one is the downsloping ST segment depression, which is most specific for true ischemia. The upsloping ST depression is often seen with faster heart rates, and the horizontal ST depression is also sensitive and specific for ischemia. Given how important ST segment depressions are, once again, the first slide shows horizontal ST depression. The second one is associated with a bundle branch block, but there's downsloping ST segment depression, and the third one has an upsloping ST segment depression. Now there are some curveballs. A commonly overlooked ST segment in AVR. Elevation in AVR is highly predictive of significant coronary artery disease. So always look at AVR if there's elevation or changes, alert the interpreting physician. When the patient is subjected to a standard Bruce protocol, calculating the Duke treadmill score is quite important. It involves measuring the total time that the patient exercises, the degree of ST segment depression in millimeters, and whether or not the patient had chest discomfort. The chest discomfort is subclassified into limiting or non-limiting chest discomfort. For a patient who does not have any ST segment depression or has any chest discomfort, the Duke treadmill score is directly equal to the number of minutes on the treadmill on a Bruce protocol. So if I were to walk 7 minutes on a standard Bruce protocol, have no chest discomfort, and no ECG changes, my Duke treadmill score would be 7. Otherwise, the Duke treadmill score is calculated by exercise time in minutes is used, and then from that 5 times the ST deviation is subtracted and 4 times the angina score. However, this is done by the interpreting physician, and you do not have to worry about that, but know this. So as I shared, calculating the Duke treadmill score requires a bit of math and can be done using online calculators. and it can be done after the test is complete. A moderate risk score is anywhere between -10 to +4. A low risk score is greater than 5, and high risk score is less than -11. PVCs occurs commonly, however they should decrease with exercise. If PVCs increase in recovery, they are considered to be high risk findings. Alerting the interpreting physician and including that in the preliminary report is quite meaningful and helpful. Lastly, but not uncommonly, the patient may develop a bundle branch block with exercise. Sometimes it is rate related, other times it is caused by ischemia, and it is almost impossible to differentiate in the absence of chest pain. Overall, it should be considered as a marker of increased coronary artery disease risk and underlying conduction system disease. Clinical correlation by the interpreting physician is essential for future workup. So in the last 18 slides, we have covered some basics about stress testing. Please do not hesitate to ask questions of me. You can email me, you can connect with me at the office, and I hope you enjoyed and learned how to do good quality stress testing. Thank you.